Good evening, everyone. I'm Dr. Damodar Reddy, consultant cardiologist in Medicover Hospital, High Tech City, working with Dr. Sharath Reddy, sir. Today, we are going to discuss a case of IVUS-guided multivessel PCA with RCA CTO PCI. I'll be discussing the clinical details and the angiogram and the plan. Dr. Sharath Reddy, sir, will be discussing regarding the live in-box case. So coming to the clinical history of the case, it's a 55 years old gentleman with class 3 F1 angina since last 3 months. And he had worsening of angina presenting with rest angina for last 3 days. And when he came, we tested the troponin, it came positive. And he had good LV systolic function. With the background history of chronic diabetes and chronic hypertension, he was never a smoker. And his creatinine was 0.9 with EGFR of 94 ml per minute. This was his ECG, and you can see there are some mild T inversions in the LITRI and AVF. Otherwise, it is unremarkable. This echo was showing no RWMI, good LV and RV function with normal valves. So coming to his angiogram, we'll see first his left system. You can see it's the epicaudal view. His left main was normal, and you can see there is tight, almost 90% tight stenosis in the proximal LCX with the post-stenotic mild dilatation followed by plaque. And this epicranial, you can see clearly there is a proximal and medullary significant disease. And you can see distal RCA is filling retrogradely from the left system. And when you notice the LAD, you can see there is small ectasia versus occluded, possibly occluded diagonal versus ulcerated plaque here. So cranial. Levocaudal, again confirming the tight LCX lesion and retrograde flow into the RCA. This LAVO view demonstrating the distal RCA filling to look for the septal collaterals. You can see clearly there are good septal interventional collaterals filling the distal RCA from LAD. Coming to the right system, you can see clearly the proximal RCA has two tandem lesions, critical almost 80%, followed by mid RCA short segment total occlusion. And you can see distal RCA filling retrogradely from the homocoronary collaterals from the proximal RCA. You can see there's a good distal target. This RAO view, and you can see clearly there is a short segment CTO, and possibly there could be a bend in the CTO segment of more than 45. And we routinely do anatomy before planning a procedure. We generally, after assessing the coronary angiogram and the fluoro, our protocol is to do draw an ANATOMICOGRAM and reassess the angiogram visually and plan the case. So here in this case, you can see what we have drawn is LAD 80% disease, and what I've shown the LCX disease and short segment mid RCA CTO. This is a JCTO score. Proximal cap looks ambiguous with less than 20 mm of short segment CTO with more than 45 degrees of angulation, and no significant calcium seen with good distal target and good intervention collaterals. The JCTO score comes to around 2. And you can see there clearly good septal collaterals filling the PDA and PLVB. As I discussed, this is a JCTO score of around 2. Since the multivessel CAD, we calculate the syntax score 1. It came to around 22, and syntax score 2. For PCI, it was 19.6%, and for cabbage, it was 12.8, almost low risk for CABG and also PCI. These are surgical scores coming for, it's a low risk scores, both STS and Euroscore 2. So further, Dr. Sharath Reddy sir will be discussing the live in-box case. Thank you so much.
Yeah, since this patient had triple vessel disease with a syntax score of 22 and is a diabetic and normal LV function, so we kept this case in our team, and we had a discussion. So we gave both options to the patient, but finally, patient also opted for PCI. So we went ahead and did triple vessel PCI in a single setting. So I think, shall I start or should we wait for Dr. Samin Sharma?
Oh, I'm here. I'm here now.
Ah, sir, yes. Done. Yes, sir. So since we have only 40 minutes, I'll rush through the left system, and then we'll focus mainly on to RCA CTO. Before starting, probably for our viewers' sake, we can also discuss which vessel to attempt first, RCA or LAD in this or left system or RCA in this patient.
So no, knowing that you are deciding multiple, and we always try to do a more complex case lesion first.
Yes.
And with that note, I think both are all reasonably, but not very super complex, but reasonably doable lesions. So I probably will start with the right.
Yes, sir. And also, since this case we thought of most likely we may end up in retrograde, I'll show you the reasons why we thought we may end up in retrograde. That's the reason it's always better to treat LAD before we go retrograde in such tight lesions. Yeah. So there is a tight lesion in LCX, and LMCA and ostial LCX and ostial LAD apparently looks okay angiographically, but we can see in imaging where the plaque is actually even extending into LM. So what we did is we just dilated LCX first. We have not wide LAD, so because to get a good imaging of LMCA, it has to be done only with one wire. When you keep two wires, which we have discussed in last case, so obviously it screws up our imaging. So we did IVUS from LCX after pre-dilatation with a 2.5 balloon. So though it is not equivalent to the size of LCX, we did IVUS. So you can see this is LCX IVUS. So there is a calcium here around 320 degrees, and you can see the length is overall length of the plaque was around 32 when I took from ostium. But when I see ostial area, so ostial area was quite good. It's like 7.2 mm square, though the plaque area was around 60%. So what we decided is, we can leave ostium of LCX and no need to extend stent into ostial LCX. And then we started wiring LAD because if I have to extend LAD stent into ostium, then I would stunt LCX first and go to LADC. It's based on which vessel to stunt first will decide where stent has to be extended into ostium. So that's the whole idea of doing imaging from both vessels. So we wide LAD and we did IVUS. You can see this is the IVUS. We can see here. So I'll pause for a minute. Probably you can see here at 3 o'clock in LAD. So there is an attenuated plaque which is well visible, I think between 1 to 4 o'clock. So 1 to 4 o'clock. So it's an attenuated plaque. So, and these are the plaques which are quite dangerous, which can produce, it could be a necrotic core or lipid-rich plaque, which may produce, no flow after stunting. So generally, we try to avoid doing too many post-dilatations in this area of plaque. So this is IVUS. So in the interest of time, I'll just push it. So pull it. Yeah, and I'll show LMCA because this is something which plays a major role in my stenting strategy. You can see here, so this is an LMCA, yeah, this is LCX joint, yeah, this is LMCA, this LM. So we can see the area is almost 10.8, but you can see the block is extending. So there is a 58% of block area. Here it's around 8.4, and there is 59, nearly 63% block area. And you can see here, so it's been 8.8 mm square and 65% block area. So overall, MLAs are good in LMCA. Yes, though block areas are a bit more, we decided to go ahead with stunting ostial LAD. We can see when we look at ostial LAD, ostial LAD area was like 4.2 with a block area of 70. Probably, yeah, I can, yeah, you can see here. So this is 4.8 is the ostial LAD, and there is a significant block area, so which is quite well visible. So looking at this, ostial LCX is around 7.2 mm square with a block area of 60%. Ostial LAD is 4.8 with a block area of 72%. We decided to extend LAD stunt into ostium, and that is the reason we decided to stunt LCX first, followed by LAD stunting. So yeah, I'll just move on to one graphic, which this is all LMCA and this LAD. Yeah. Video is playing. I think there is some technical.
No, it's a slow.
Yeah. So this graphic, which clearly shows, sir, are you able to see the graphic, sir?
Absolutely, yes.
Yeah. This shows all distal differences. My main interest area is the ostium and LM. So as I already mentioned, lumen areas are quite good. We decided to leave LMCA, and ostial LAD block area is 72% with MLA of 4.8. We decided to stunt from ostial LAD, and LCX there is almost 7.1 mm square with a block area 60%. We decided to stunt LCX beyond the ostium. So yeah. So that's what we decided with imaging, and then we went ahead. Yeah. So this is LCX stunt. I believe it's 3.521. So Giant's expedition, so we stunted LCX, and then we optimized LCX lumen areas with the 3.5 NC balloon. And we can see now comes the lumen areas after post-dilatation. We have good lumen areas. So almost more than 8 mm square all through. You can see, so it's a 7.1, so 9.6, 10, and this is actually 8.2. We are adjusting still. It comes around 8.2 here. Again 7.7 and 9.6. So we left it LAD at this juncture. LCX at this juncture. We moved on to LAD, and this is the length which we have got in LAD, and the distal difference was like 2.7, 3.1. It's around 2.9. So we took a 3 stunt, I think 348, since the length is nearly 42 millimeter. I'll skip this. So this is 348 stunt. So one advantage with IVUS is we can truly locate ostium by keeping IVUS and giving an injection, and then we position stunt exactly there. That's what we have been doing since last couple of years. So quite often our landing zone at the ostium is quite favorable, when we take it with an IVUS. So we deploy it with the same technique. So putting the reference of IVUS above, and then we optimized proximally with the balloons, taking according to image guidance. I think proximally we dilated with a 3.5, and at the ostial area we also dilated with a 4.0 balloon, and distally we dilated with a 3 balloon. So this, I think then we did IVUS. Yeah, I think these are the IVUS areas. So we have got good IVUS areas. It's more than 7 mm square throughout, and the distal difference was around 6.4. Yeah. And this is LMCA. Yeah. So this is a final angiogram of left system post stunting. So showed good result. Yeah. So then we moved on to right coronary artery CTO. So we took AL of, this is what happens, once you put EBU in left system and then take AL, AL always pulls your EBU out. So we can take an RAO view and push AL down and then, try to engage. So that technique really helps. So that's what we did here. So then, yeah. So, yeah, we took a dual injection. So this is, I think for all youngsters, this is the norm where we have to start CTO. So you can see it appears like a very short segment CTO. When you look at the proximal vessel of RCA, proximal RCA, proximal to CTO, I paused it. There is a lesion here. There is also lesion here, proximal to the proximal cap. And we can see this is a PDA. And the PDA entry into right coronary artery, the angulation is quite abnormal. So whenever we go retrogradely, the wire always goes into, the PLVB. It's very, it's difficult to direct our wire, into the proximal RCA. So that's one challenge. So it's not a good angle for a retrograde. Anyway, we have a good vessel here. So, and and there is one branch, small branch here. So it appeared it's a short CTO, but I'll show you during the course of CTO what problems I faced. So in this case, as the proximal cap is pretty clear, it's not ambiguous, and the distal vessel is also quite good. So it's a good case for antegrade wiring. So there is a good entry point where I can start my antegrade wire, and there is a good distal target where I can end. So we thought of going ahead with antegrade wiring. But before starting my wire escalation, I would obviously open these two lesions which are present in the proximal RCA to make my job easy in the due course of procedure to send guideliners, if at all, if I need externalization or any, ADR if I end up. So what we did, we took a workhorse wire, we dilated with a 2.5 balloon. So both the lesions. So, and then advanced corsair into the proximal to the proximal cap and took an injection with corsair and, retrograde. Now you can see actually there is coarse ambiguity here. So which in fact I underestimated before I entered this case. So in RAO, there is a clear coarse ambiguity, which truly I underestimated. And yes, okay, so we started wiring. my wire escalation, the first wire is generally we start with Gaia 2. So this is the Gaia 2. So, but despite spending, good amount of time, the wire didn't progress beyond this point. Since I had a doubt on the vessel course, the course looked ambiguous. I felt, this penetration wides sometimes, they create problems. So that's the reason, I moved on to Pilot 200 because it was not available. I took a Gladius wire, which is almost equivalent to a Pilot 200. So we took a Gladius wire and we tried advancing, Gladius wire. But even that didn't get advanced, we were just stuck there. So it looked, it's a highly calcified lesion. And the proximal cap is not giving any scope for these two wires. Gaia 2 is like 3.5 grams and Gladius is almost similar tip load. So neither wire is progressing. So that's when I decided to escalate it to Gaia 3. I think this is Gaia 3. So normally from Gaia 2, generally we take, I'll go to Harnett wire because we're going to Gaia 3, it's only like a 1 gram increment in the tip load. But in this case, as the course was ambiguous, I didn't want to take, Harnett wire because these wires, unless you know the course, we shouldn't use it. So we took a Gaia 3 and in fact, it progressed a little bit. So yeah, it just made a little bit progress. You can see, yeah, so yeah, so it made a progress and yeah. So it made a progress. We can see here, yeah, we do inject and see now. Yes. So, but if you see, the course of the wire, it was quite, different when compared to the location of the, distal vessel. So that's what. That's what it had been going on in my mind, during procedure. So the course was quite abnormal, but you can see here again, the wire was, we don't know, but the overall movement of the wire looks, it is within the vessel architecture, but when you try to, join the points by fluoro, it's not quite favorable position. So at this juncture, so what is very important, for me is, I have to get a clarity on my distal cap. So unless I have a clarity on my distal cap, so I can't really continue with this antegrade wire escalation. So that's when, we decided, we have to go ahead with retrograde. So, no, sorry. So what I decided here, before going to retrograde, we thought of going ahead with the knuckle wire. Because since knuckle wire, any ambiguous course, knuckle wire is a good strategy. And there is a good re-entry also before PDA here. So I thought of going ahead with the knuckle wire. So, yeah. So you can see for doing knuckle here, so I had to take a parallel balloon, to the microcatheter and trap the microcatheter to get a good support to your knuckle. And then you can see here, so this is, I tried both Fielder XTR and Gladius wire, but knuckle was not progressing. So both Gaia 2 didn't progress, Gladius wire didn't progress, only Gaia 3 progressed and reached, so the distal part of the CTO, and knuckle couldn't progress, beyond this point. So that clearly says, there is a there must be some calcium in the proximal cap, and it's very hard proximal cap, probably. So since I'm knuckling, within the lumen, it's not I entered into the subintima before starting knuckling. So we can see here, knuckle did in progress. So since this attempt of ADR also failed, then I decided to go ahead with retrograde strategy. So yeah, so then what we did, yeah, so and from here, so we started our retrograde. Yeah, okay. Yeah, so this is a cyan blue wire with Caravel 150 microcatheter. So, and we positioned microcatheter into, so yeah, the septal which I wanted to see. This septal is beyond my LED stent. So it's beyond my LED stent. So we have not jailed this septal. Yeah, you can see, not that, yes, that one. Okay, so, and it's a CC2 collateral. Yeah, so this is a septal, so which we wanted to traverse. So this is a Caravel 150. And then, we took shots, microcatheter injections just to confirm the course of, collateral. And then we switched to a cyan wire. So this is cyan wire. So cyan wire, we went with directed tracking. It's not surfing because it's a CC2 collateral. So you can see how it's just going. See, there are definite loops within the collateral, but so if you spend time on wiring without much push, with each systole and diastole, wire keeps progressing. So that's what happened here. It progressed, and I think slowly it enters PDA, without much difficulty. See, we crossed a septal within probably 2 minutes time. So I'm advancing, Caravel just to take support for my wire advancement. So, but always try to keep, microcatheter beyond 5 millimeters from tip, so that your wire won't damage your collateral. As you go closer to the wire tip, your tip load of the wire increases, and tip load is like around 0.6, 0.7. So when you take your microcatheter close to it, it will increase by, at least 2 steps up. So you can see there are a lot of loops, and which we are observing in between. And yeah, you can see here. So yeah, we nicely crossed collateral. Yeah. Okay, so then we advanced our Caravel catheter, microcatheter, Aldous 4, yeah. So we advanced Caravel microcatheter, and you can see how the wire is going quite easily. And you can also observe wire is just going into PLVB, which we told in the beginning. So this angle is a quite bad angle. So to divert my, direct my wire into the distal RCA. So, but what I wanted here is I want a clarity on distal cap by retrograde injections. So that's a main thing, which I wanted, because that clarity I was not getting by non-selective retrograde injections. When I put a microcatheter close to the crux and do inject, then obviously I'll get a good, distal cap visualization. Now you can see, yeah, so I can see the vessel close to the distal cap. which was not quite well visible before. And also, when I'm injecting from retrograde vessel, entire vessel architecture is actually disturbing my eye. Here, it's quite clear. So I'm only injecting to the spot which I'm interested in. So nothing else is disturbing my vision. So then we restarted antegrade wire escalation. I directly took Gaia 3 since Gaia 2 and Gladys didn't work in this case. Yeah, so this is a Gaia 3 wire. You can see, if you look at the course of Gaia 3, the course was actually similar to what I went in the first time. So the problem was the first time I didn't have the clarity on the distal cap, because of which I couldn't advance this with this wire. Because if you don't know where your distal cap is, distal vessel is, you tend to just go, perforate the vessel with these wires. So it should be only directed tracking, with these wires. So yeah, so yes, you can see now. So the wire went in the same direction. So as I went in the beginning, and while advancing my wire, see, we keep injecting, just to, yes, now we can see it is quite clear. So there is a nipple visible at the crux. So, and my wire is onto that nipple. So now it is clear for me. And yes, and the movement of wire is also good. It is within the vessel architecture. So, and we kept advancing. Yeah. So we kept advancing wire. So taking that point, visible with microcatheter injection. Yeah, now you can see, actually, as my retrograde microcatheter came back, I had to again rewire and push the microcatheter up. And in fact, I'm also trying to see both the wires. Yeah, so this graphic actually, says, see, in LAO view, the vessel was looking like this, but this is a nasty view for this case. So, and you can see in RAO view, the vessel was like this. It's not, see, what our eyes imagine is the straight course always. But in this case, it is not the straight course. It is coming like this. So that is very, very important, while understanding, or, sending this high penetration wires. So you can see here, so how the vessel course is. And now what I'm doing is, see, I almost reached close to the distal cap. So what I wanted to do here is, go to an ideal view, that is for this area. I generally use LAO caudal and LAO cranial views, and inject from your retrograde microcatheter and understand the relation of your wire with the vessel. So that's what I'm doing here. So we can see, I think this is LAO view. Yeah. So the wire movement is quite good. It says it is within the vessel architecture, but surely it is subintimal. It's not in true lumen. It's not in true lumen. And then we moved on to kind of 3D wiring. And before that, we have to understand, how to, yeah. So you can see this is LAO cranial. I think we almost did by this time. So, okay. So we took both LAO cranial and LAO caudal views, and then rotated the wire clockwise and just pushed it 90 degrees. And then we actually reached true lumen. Now you can see this is LAO caudal, wire is looking true lumen. So both in LAO cranial and LAO caudal, wire is in true lumen. This is Gaia 3 wire. Now you can see I am doing a slide test. So I just slided wire. So wire is just going freely. So that says we are within lumen. So it's within the lumen. In 2 views. So it's just progressing, simply. Yeah, it's progressed. So without much issues. So then we started, dilating CTO segment, and the balloon was not going. I didn't want to advance, Gaia 3 wire beyond this point, because again, it may go subintimal and damage our distal vessel. So it's always better to exchange wire with a microcatheter after creating a space in the CTO. So that's what we are doing here. So we took a 1 mm balloon, and this 1 mm balloon was not going in. Then we decided to go ahead with an anchor balloon. So anchor balloon, we took an anchor. Yeah, so I think we took an, yes. So we took an anchor. So this is an anchor. I think it's a 1.5 mm balloon. And then we advanced. You can see here now the balloon actually reached the distal part of the CTO. And we dilated. And then we exchanged the wire to Workhardt's wire through Corsair microcatheter. You can see this is a Corsair. And this is the Workhardt's wire, which is advancing, quite nicely into the distal RCA. And then I think the rest of the job is simple, but yeah.
But very tremendous job, very tremendous persistence and guiding with I think one of the key was your injection. So the car valve in the retrograde channel. I mean, that was really telling where it is. So this was very remarkable. How the patient tolerated, this must be a few hour procedure.
I think it took us around, the whole thing is around, probably around 3.5 to 4 hours, sir.
Yeah, right.
So he's a young guy, 49-year-old. So we didn't have much problem. So I would like to show IVUS, a quick IVUS for viewers to understand, what is my wire tracking. So yeah, I'll just show the initial part of IVUS, and then we can directly go to the optimize. Yeah, you can see here. So yeah, it's a PLVB. We are in true lumen.
Yep.
And you can see this is PDA at 2 o'clock. And now you can see, I think I'll just stop. Yeah, you can see at 2 to 3 o'clock, there is a true lumen. Actually, this is a compressed true lumen. So PDA is coming from true lumen. Proximal to PDA, I re-entered into the vessel. That's where, we did 3D wiring. So this is, true lumen, and my IVUS is actually in the false lumen here. So I can show, it's a very short segment subintimal course. You can see still at 2 o'clock, it's a true lumen, which is compressed. So true lumen, which is compressed. Yeah, now we came back to true lumen again. So it's around 8 to 10 millimeters of false lumen, and rest all is true lumen. And you can see the calcium, the amount of calcium. So which makes us understand, why Gaia 2 Gladius and Akal didn't work in this case when I tried going through, true lumen. So, and with IVUS, this thing, we decided stunt sizes, everything, and then we went ahead with the 328 millimeter stunt distally. Since I re-entered before PDA opening at cracks, I'm sure PDA won't compromise in this case, but there is a small branch proximal to the PDA which would compromise, which we are aware, but it's a very small branch, we decided to leave it. Yeah, and next stunt, we took a 3.5 38 millimeter covering an entire proximal lesion, and yeah. So, and then we did IVUS, based on IVUS block areas and lumen areas. We optimized, stunt with multiple balloons. So distally 3 balloon, middle 3.5, and proximally almost 4 balloon. So optimization done with IVUS sizing. Yeah. So I think, yeah, this is, yeah. So this is 4 millimeter balloon, and yeah. Yeah, so this is IVUS. I think we have got a good MLS throughout. So we have got good MLS, and then probably I'll show you check angio. You can see here final angiogram. Yeah, so nice. Yeah, so this is a final result. So PDA is intact, but the small branch which was there before has gone, which we anticipated. Yeah, but the rest of the distal circulation is filling quite nicely, and stent expansion is quite good. So yeah, so once we confirmed good lumen areas with the IVUS, then we moved on to left system. So in this case, basically, yeah, I have to remove microcatheter. So you can see here, this is a microcatheter which we pull back, pull microcatheter back, and yeah, so we did a check injection, make sure collateral has not ruptured. We have not caused any damage to collateral. Yeah. So collateral is nice. So, and in this case, because since there is a stent and a donor vessel has a stent, it's prudent to do an IVUS before coming out. I have a couple of cases where we did retrograde through stent in donor vessel. We might end up in dissecting vessel at the end of the stent because of the shear stress which we are going to create while pushing our microcatheter. So that's why always it's important to check distal stent edge. So which you can see here. Yeah, you can see here the distal stent edge is perfect. So there is no issue with the distal stent edge. And the second is we should always see even proximal stent edge because in the process of pulling retrograde microcatheter back, we might end up in sending our guide deep into the donor vessel stent, which may damage stent strut. So we have even checked that, and then I think I think that's, and so it's all fine. So the stent expands, the proximal stent was good, and the distal stent edge was good. So then we left it there. Yeah. This is the end of my case, sir.
Beautiful. Fantastic. So no, the last, we just need to see the last picture, right? On the left side?
Because I have not done, I think. Because we did IVUS, so IVUS was fine. We just left it. Yeah.
No, but this is Sharath and the great team. I mean, this is a phenomenal results of very complex intervention, and step by step guiding with the imaging and persistence, and come with the great results. So this has been a great day. I hope our audience, everybody else, learned quite a bit from both the case in box as well as the live cases and the rest of the discussion. If I don't see any questions further in the chat, and so this seminar continues. Number episode.
Yes, some questions in chat box, sir.
Yep. Go ahead, Damodar.
Yeah, Dr. Uday Shankar question is, how can you say which one is true and which is false lumen in the IVUS?
So yeah, I'll just probably I can even take back my video and show them. See, normally we have to see only one lumen. Okay, so it's like one circle. So if you are seeing a circle in a circle, So that means, and your IVUS is actually in one zone. The other circle is on the other side. So that second circle is nothing but, generally it will be like a kidney shaped this thing. That second circle is nothing but your compressed true lumen. So yeah, I can show here. You can see here. So you please concentrate on, yes, you please concentrate here. I think you are able to see my arrow, Damodar?
Yes, sir.
Arrow is, yeah. So see, this is my IVUS. This is my IVUS lumen, right? And this is the other lumen. Actually, this is the original true lumen. So we have, yeah, you can see. So there is a good, speckling which is visible here, and it's almost a circle in a full circle. So R, a kidney-shaped structure within a full circle. So this is nothing but true lumen, and where my IVUS is, this one is actually false lumen. Yeah. Okay.
So what was the amount of dye used? I would like to answer that. It was around 200 to 220 ml.
So in this case, as we don't have a retrograde route, because the retrograde wire was actually not going into the distal RCA, we had to use more contrast. Otherwise, it would have been over less than 100 ml. Yeah, because I have to keep injecting, through the retrograde system to understand my wire relation to the distal vessel and do wiring. So that's when, we end up in more contrast. Yeah.
And also it was multi-vessel. So
yeah, it's a multi-vessel. Yes, of course. Yeah.
Okay, beautiful. Any other questions left?
Think.
Okay.
Yeah,
so
that's it.
We can stop the screen share. As I mentioned, excellent teaching points made at every step on this live in box case. Phenomenal. Definitely, need to congratulate Sharath and team.
Thank you, sir.
Beautiful.